Hello, everyone. Welcome to this plenary session on oral abstracts from a variety of different esteemed guests. We're sure to learn a lot today, and I will kick things off by introducing our moderator today, Dr. Shipra Kaker, and then she will introduce our speakers for their presentations. So Dr. Shipra Kaker is an associate professor of clinical pediatrics at Weill Cornell Medicine and an associate attending pediatrician at New York Presbyterian Hospital. She specializes in pediatric hematology with expertise in platelet disorders, immune cytopenias, anemias, sickle cell disease, and bone marrow failure syndromes. Board certified in pediatrics and pediatric hematology oncology, Dr. Kaker brings extensive experience in both clinical care and research. Dr. Kaker actively participates in clinical research focused on childhood immune and hematological disorders. Her commitment to patient care has been recognized through multiple awards, including the Beloved Doctor Award from Maimonides Infants and Children's Hospital. And she's a top 10 doctor in the metro area and state, and the Patient's Choice Award back in 2012 and 2013. So thank you so much for being here today, Dr. Kaker, and we look forward to the rest of the session. Over to you.
Thank you so much, and I'm honored to be invited as a moderator for this session. Good morning, everyone. Welcome. We have a tight session with three amazing speakers who will be presenting our oral abstracts. And I will just begin by a couple of housekeeping things. To please remain muted. You can definitely type in your questions in the Q&A box below. You can also, if English is not your first language and you would like to see this talk with captions in your language, please click the captions button as well. We will save all the questions to the end. We should have about 10 minutes to ask questions, but please feel free to put questions in the Q&A if you have them as the speakers are speaking. So I have the honor and privilege of introducing our very first esteemed speaker, Dr. Andrea Kasner, who is a professor of medical imaging at the University of Toronto and a senior scientist in the translational medicine program at the Hospital for Sick Kids in Toronto, Canada. Dr. Kasner uses quantitative MRI, and she interrogates the complex interplay between various physiological parameters that maintain brain function. In particular, she's interested in the hemodynamic, metabolic, and structural mechanisms of cerebrovascular disease, and especially for this particular conference for children with sickle cell disease who have risk of stroke and cerebral angiopathies. So I think Dr. Kasner today is going to be talking to us about characterizing cerebrovascular dynamics in children with sickle cell disease using quantitative MRI. Dr. Kasner, you're very welcome to this conference, and the floor is yours.
Thank you, Dr. Kaker, for this nice introduction. Good morning, everybody. So next slide, please. So cerebral blood flow is tightly regulated to ensure sufficient oxygen supply to the brain. And the physiological mechanisms mediating blood flow in the brain are cardiac output and vascular resistant. So at the macrovascular level, vessel tortuosity and vasoconstriction finely adjust blood delivery to the brain and to meet local metabolic demand. And at the microvascular level, vasodilation and vasoconstriction finally adjust blood delivery. So together, these mechanisms help maintain stable oxygen supply to the brain. Next slide, please. So in sickle cell disease, the ability to alter blood flow in the brain is impaired, resulting in an increased risk of hypoxic injury. Two major symptoms associated with sickle cell disease are anemia and endothelial dysfunction. So anemia in sickle cell disease is caused by the red blood cells having a short lifespan and being destroyed faster than the body can replace them. So that leads to increased cerebral blood flow in the brain so that, enough oxygen is transported to the brain and to compensate for this low oxygen carrying capacity of the red blood cells. So I have a picture here. You see on the right side here, the sickle cell shape of these red blood cells in patients with sickle cell disease compared to the donut shapes, which is what we type as AA blood compared to the SS type. So for endothelial dysfunction, that is caused by a combination actually of factors, including nitric oxide bioavailability. There's a lack of in sickle cell disease. So what that means is that NO is actually a vasodilator. So we have impaired vasodilation and vascular tone. There's inflammation and adhesion of these sickle-shaped red blood cells to the endothelium, which is the inner lining of blood vessels, which then can lead to micro and microvascular occlusions. Next slide, please. So under normal conditions, cerebrovascular function maintains optimal oxygen delivery through vessel flexibility. But in sickle cell disease, as I already mentioned, that we have disrupt vascular tone and responsiveness and leading to abnormal blood flow. There's vascular stiffness, microvascular resistance increases, and these abnormalities impair cerebral perfusion and increase the hypoxic injury risk. So with MRI, we can, however, image these parameters to get a good idea of vessel function non-invasively. And that will give us a valuable insight into disease mechanism and progression, and also to monitor treatment response. Next slide, please. So some of the MRI techniques we use are, for example, time of flight imaging, which I abbreviate here as TOF, where we can get a structural image of larger arteries. Then there is a technique called arteriospin labeling. So we can measure cerebral blood flow. That's the image in the middle. That's what the image looks like. And then a technique called BOLD CVR. BOLD stands for blood oxygen level dependent imaging with MRI. CVR is cerebrovascular reactivity, to look at blood flow changes in response to a stimulus. And we call that cerebrovascular reactivity. So all these three image types I put down here. So you see the vessel tree here. So that's time of flight imaging, cerebral blood flow inside the brain, and then cerebrovascular reactivity. And the blue shows you really the lack of. So there is where the brain is at danger. Next slide, please. So another method I'd like to introduce, what this presentation is about today, is a parameter called pulse wave velocity and reflection coefficient. Pulse wave velocity describes the propagation of speed of pressure waves in the vessels, and the reflection coefficient, which is gamma, describes the partial refraction that is generated when pressure waves encounter downstream change in the vessel morphology. So we can compute this relationship between the two of them from blood flow and vessel size, and that's what we get from a technique called phase contrast MRI. Next slide, please. So our study aim was to measure pulse wave velocity and gamma, the reflection coefficient, in children with sickle cell disease and healthy controls, and correlate these measures with CVR, the reactivity measurement, and cerebral blood flow using quantitative MRI. Next slide, please. So we had 7 pediatric sickle cell patients who participate in our study, mean age around 14. We had 4 females, 3 males, and 3 age-matched controls. And our MRI protocol was performed or executed on a 3 Tesla MRI system. And we used the 3 techniques I briefly described before: phase contrast MRI, BOLD CVR imaging, and arteriospin labeling. Next slide, please. So then we performed some data analysis, right? The details would take too long to get into that, but we have some custom software tools where we can segment the vessels and then compute pulse wave velocity and the reflection coefficient. And we can also generate maps of CVR and CBF using a package called FSL. Next slide, please. So for the results, you can see on the images. So these are typical images we get, showing here on the left. That's a CVR image in a sickle cell patient compared to a CVR image of the control. I hope you can sort of see, looking at the scale here, that the control has much higher CVR. And for CBF, it's the other way around, because the oxygen carrying capacity is so much less in sickle cell disease. For the red blood cells, we have higher CBF versus CBF in a control. So that is nicely shown here. So our analysis actually revealed that clear vascular differences between sickle cell patient and healthy controls. The mean pulse wave velocity and the reflection coefficient, as well as CBF, were also significantly higher in the sickle cell group. And in contrast, CVR was lower in sickle cell patient, as I've just shown you on the images. And among all variables, gray matter CBF showed the strongest group difference with a correlation of R of 0.91, and it was strongly associated with both CVR and gamma. Additional pulse wave velocity and gamma were highly correlated, suggesting a link between vascular stiffness and wave reflection in sickle cell disease. So you can see this violin plots here, which shows you sort of the distribution of all these measures in sickle cell patients versus healthy patients. So you can see there is a clear difference between these. So they were all statistically significant. And on the right, you see a heat map, which shows you the Pearson correlation of all these measures and groups. Next slide, please. So in conclusion, using phase contrast MRI and whole brain MRI measures of CVR and CBF, we were able to obtain high spatial and temporal resolution imaging of the common carotid artery. That's where we get wave reflection and the pulse wave velocity from to assess perfusion. And we compared that to whole brain measures of CVR and CBF. So we identified significantly flow and reflection differences of the common carotid artery between sickle cell patient and controls. And these correlate strongly with the CBF measurements in the brain. Differences suggest that the common carotid arteries in sickle cell patients are less compliant and blood delivery into the microvasculature is less efficient. These parameters, we think, offer significant insights into cerebrovascular mechanisms, which are impaired in SCD patients, and may aid in clinical evaluation of children with cerebrovascular disorders in general. And we hope to use these measures to predict in future the risk of infarct. That could be silent infarct or an overt stroke, and also to predict, cognitive decline in these patients. And that's a study we are currently working on. Next slide, please. So I'd just like to acknowledge, people in my lab and collaborators, as well as the funding agencies, and thank you for your attention.
Thank you so much, Dr. Kasner. That was fascinating. As a sickle cell provider, it's wonderful to see new technology coming up that can predict, cognitive decline and stroke in our patients. So I'm hoping to see more of your work very soon. I will now introduce our next speaker, Mrs. Darshi Vyas. Mrs. Vyas is a dedicated physiotherapist. She has over 10 years of experience in the government health sector. She holds a master's degree in neurology from the Indian Spinal Injury Center, New Delhi, India. And she specializes in the rehabilitation of spinal cord injury patients. And she has helped women a lot, in particularly women with pelvic floor rehabilitation, restoring function and well-being. Currently, her professional focus has been more on the management and rehabilitation of patients with sickle cell disease, and her work really emphasizes physical activity, prevention, and corrective interventions that are aimed at reducing deformities, enhancing mobility, and improving quality of life for these patients. So with a strong commitment to evidence-based practice and patient-centered care, she's really dedicated to empowering patients with sickle cell disease through rehabilitation strategies that promote their independence, resilience, and long-term wellness. So Ms. Vyas, welcome, and we're really looking forward to your abstract.
Thank you so much, Dr. Shipra, for inviting me here as a speaker. So I am starting here now. I'm presenting here in International Congress. Topic will be variability of musculoskeletal and pulmonary symptoms and need of physiotherapy in sickle cell disease. Next slide, please. Introduction. Sickle cell disease is a hereditary blood disorder characterized by the production of abnormal hemoglobin molecules that cause red blood cells to take on crescent or sickle shape. The clinical manifestation of sickle cell disease are diverse and can vary in severity among individuals. Musculoskeletal involvement and pulmonary symptoms in SCD are also common, and various joint pain is found even other than VOC. Experiencing pain in physical activities like cross-leg sitting, sweating, standing, walking, and running are common problems, and its elevation in certain degree reduces physical activity, increases the rate of disabilities among these individuals. Thus, exploring the need of physiotherapy in sickle cell patient is warranted. Next slide, please. Methods what we have used at our center. It was a retrospective study. The duration was 2 months and it is also ongoing right now. So the data which we are presenting here is from 2 months from July to September 2025. Location was Center of Competence of Sickle Cell Disease located at RNT Medical College, Udaipur, Rajasthan, India. We have consulted 105 sickle cell disease patients with the relevant symptoms in 2 months, which were presented in outdoor of are sickle cell OPD and IPD patients, and their follow-ups were also included. Next slide, please. Our data collection process included all the patients with any kind of joint pain or pulmonary symptoms that presented to physiotherapists in OPD, IPD of SCD patients. Proper passive range of motion of affected joint, activities of daily living and gait were tested. MRI of hip pain patients were also done to detect AVN. To the relevant patient, deep breathing exercises, segmental breathing exercises, incentive spirometry, range of motion of affected joint, stretching and strengthening, and relevant stretching and strengthening of relevant muscles, back and neck strengthening and positioning and gait training were prescribed to all the patients. Next slide, please. Results. As I have mentioned, we have consulted 105 sickle cell disease patients. Those who were from OPD and IPD and also follow-up are included. 84 unique patients were there. Total male patients were 44 and female were 40. This female was 48% and male 52%. Mean age of patient was 17.4. Next slide, please. Now we talk about most common symptoms. What we have found was hip pain and back pain. So musculoskeletal symptoms were found. Most common were hip pain and back pain. Other symptoms were knee pain, lower limb pain, chest pain, elbow, shoulder, wrist, and neck. And very less common was MCP swelling, heel pain, and stroke also. Next slide, please. Out of those symptoms, what we have found, pulmonary symptoms were 13%. 13% of patients presented with pulmonary symptoms, out of which 64% presented with chest pain and 36% presented with shortness of breath. Next slide, please. Among the hip pain patient, what we have seen that there were maximum in the number, we also assessed range of motion in that patients. Passive range of motion, and we found that 4% patients were having reduced hip flexion, reduced hip abduction in 14%, and internal and external rotation were reduced in 15% and 16% subsequently. Thus, we found that range of motion testing of joint revealing that hip joint is most commonly restricted, especially in hip rotation, that is 31%, and hip abduction, that is 13% movements. Next slide, please. Thus, as a flow chart, if we explain 105 consultation, 84 unique patients, out of which we have found 25 suspected for AVN, according to the symptoms that was most common hip and back pain. Then we confirmed them with the MRI. So 8 were confirmed with MRI having AVN, but 6 were having classified as a Fickett and Arlett staging, which is a most common staging system for classifying AVN. 2 patients were not classified as a Fickett and Arlett staging. This out of 6, we found bilateral AVN in 1 patient and 5 patients having unilateral AVN. Then also we again classified them according to the stages. So here I have mentioned right and left hip and the staging of the AVN of these patients. As we can see, that stage 3 is most common, out of which 4 patients were having stage 3 symptoms and has been classified in stage 3 and MRI of the patient. Next slide, please. Discussion. One case study in 2022 by Vankere et al. Mentioned that 50% of sickle cell patients are prone to develop necrosis of femur, which is similar to our result, in which most common musculoskeletal symptoms is hip pain and reduced range of joint in hip. Also, the flow chart, which we have mentioned earlier, suggested that Fickett-Arlett staging stage 3 is very common in avian hip patient, which is consistent with another case study on avian hip in 2024 by Oklu AK et al., showing that most of the patient, 52.2%, were in stage 3 in their study too. If we talk about pulmonary symptoms, that 13% patients were having pulmonary symptoms, chest pain in 64% and shortness of breath in 36% were recorded. And those patients in certain spirometry and deep breathing exercises were also prescribed. This suggests need of early assessment as well as physiotherapy in order to prevent progression of pulmonary and musculoskeletal complications. On follow-up, symptomatic improvement was also observed in our patients. Next slide, please. If we conclude, hip and back pain were most common symptom found in our study, which was also restricting their joint motion, and that's why affecting ADL and reducing quality of life for this patient. This justifies the need of physiotherapy intervention in these patients. If we talk about AVN, so thus AVN should be also suspected early by assessing symptoms and range of motion. If we talk about MRI, so this should be done for the confirmation of AVN and for assessing the progression of disease in the joint. If we talk about pulmonary symptoms, breathing exercises should be suggested to patient with pulmonary symptoms. Also, there is need of spreading more awareness among healthcare professionals for referral of relevant cases to the physiotherapist in early stages. As there is very less studies in this field, so more features are recommended. I hope our study will be helpful in sickle cell disease patients for their quality of life and reducing their disability. Thank you.
Thank you so much, Darshi. That was amazing. That you had a very nice cohort of patients, and you have shown the benefit of physiotherapy in these patients who, suffer from a lot of pain, and anything that helps is really important. And physical therapy is definitely one of those things that truly seems to help. I will now introduce our last speaker, who is Dr. Vasiliki Camposu. She will be talking to us about epidemiological and comorbidity burdens in transfusion-dependent patients with thalassemia and sickle cell disease. Dr. Camposu is an internal medicine resident at the General Oncology Hospital of Athens, with a growing clinical focus on hematology oncology. She has already accomplished a lot. She earned her medical degree with honors from the National Enkephalistrian University of Athens. She was part of an exchange program in the Julius Maximilian University of Würzburg, where she participated in COVID-19 research. And she has a clinical experience spanning various healthcare settings. She is now doing volunteering in remote Greek islands through a medical landing program and participating in mobile missions supported by the Stavros Niarchos Foundation, and she offers cares to underserved communities. So we're very excited to hear about Dr. Camposu's abstract.
Thank you very much. Good morning, everyone. Can you see my slides? Okay. I'm Vasiliki Camposu, and I am an internal medicine resident. Today, I'll present our work on the epidemiological and comorbidity burden in transfusion-dependent thalassemia and sickle cell disease in Greece. This study comes from our center, Thalassemia and Sickle Cell Unit, Expertise Center of Hemoglobinopathies and Their Complications at Hippocratio General Hospital in Athens, which follows one of the largest adult cohorts of patients with inherited hemoglobinopathies in the country. As we all know, thalassemia and sickle cell disease are inherited disorders of hemoglobin synthesis and structure. Thalassemias are inherited disorders characterized by reduced synthesis of alpha or beta globin chains. They are classified according to which chain is deficient. In beta thalassemia, production of beta globin is decreased while alpha globin synthesis is preserved, leading to an excess of alpha chains that precipitate and damage red blood cells. In alpha thalassemia, alpha globin production is reduced, excess beta chains form abnormal tetramers, HBH or HB parts. The severity correlates with the number of affected alpha globin genes, ranging from asymptomatic carrier states to hydrops fetalis and prenatal death. Sickle cell disease is an autosomal recessive disorder caused by inheritance of two mutant HBS genes. The substitution of valine for glutamic acid in the beta globin chain produces HBS, which polymerizes under low oxygen conditions, such as acidosis, dehydration, and infection. Polymerization distorts red blood cells into a sickle shape. Sickle cells obstruct small blood vessels, leading to ischemia and undergo hemolysis due to membrane damage. Both are now chronic survivable diseases thanks to transfusion safety, iron chelation, and comprehensive multidisciplinary care. However, as patients live longer, the spectrum of complications has shifted from early mortality to multi-organ comorbidity. Greece has one of the highest carrier frequencies for hemoglobinopathies in Europe, approximately 7 to 8% for beta thalassemia trait and 1 to 2% for sickle cell trait, varying by region. National prevention programs introduced in the 1970s and 1980s have been highly effective and reduced the incidence of new affected births dramatically. As a result, we now have an aging population of adults with thalassemia or sickle cell disease who have benefited from decades of specialized care. This evolution makes Greece an ideal setting to study long-term comorbidity patterns in transfusion-dependent patients. Our objective was to analyze the comorbidity profile of transfusion-dependent thalassemia and sickle cell disease patients, focusing on disease-specific differences, age-related trends, specifically how comorbidity burden evolves across different age groups in both conditions, and patient-level burden. We retrospectively reviewed 105 adult patients followed at our center in 2024. Comorbidities were grouped by clinical system: endocrine, musculoskeletal, metabolic, cardiovascular, neurologic, psychiatric, hematologic, spleen-related, hepatic, gastrointestinal, renal, urologic, and autoimmune rheumatologic. Each patient was counted once per category to ensure accuracy. We also stratified by the number of coexisting comorbidities and analyzed the relationship between multimorbidity and age. This table summarizes the comorbidity distribution by disease. In thalassemia, the three leading categories were endocrine disorders, nearly 40%, musculoskeletal or metabolic, 36%, and cardiovascular, 26%. In sickle cell disease, cardiovascular complications were most common, almost 39%, followed by neurologic, psychiatric, and autoimmune rheumatologic categories, each around 15%. These patterns reflect different pathophysiologic drivers: iron overload in thalassemia versus vaso-occlusion and inflammation in sickle cell disease. This chart visualizes the contrast clearly. Thalassemia, the burgundy bars, shows a heavy burden in endocrine and metabolic systems, while sickle cell disease, the red bars, shifts toward cardiovascular and neurologic involvement. The other category includes rarer conditions such as autoimmune syndromes, retinopathy, or malignancies. As expected, age correlated strongly with comorbidity burden. In thalassemia, mean age increased from 51 years in patients with one comorbidity to 53 years in those with three or more. In sickle cell disease, on the other hand, the increase was greater, 60 to 65 years. Overall, multimorbidity clearly rises with age, reflecting cumulative organ stress and long-term treatment effects. So let's interpret these findings in a pathophysiologic context. In thalassemia, the predominance of endocrine and metabolic complications stems from iron overload, even in when chelated patients. Iron accumulates preferentially in endocrine glands, such as the pituitary, thyroid, pancreas, and gonads, disrupting hormone synthesis. We have high rates of hypogonadism, hypothyroidism, diabetes, and osteoporosis. Musculoskeletal manifestations are compounded by chronic anemia. Impressive hyperplasia of the erythropoietic bone marrow, up to 30 times greater than normal, occurs as an unsuccessful attempt to compensate for the large number of erythroblasts that die prematurely. This leads to excessive energy expenditure, growth inhibition, marked bone deformities, a characteristic thalassemic facial appearance, and severe osteoporosis. Cardiovascular complications, including diastolic dysfunction, pulmonary hypertension, and arrhythmias, are linked to myocardial iron deposition. Anemia also places a significant strain on the circulatory system, leading to hyperdynamic circulation and heart failure. In sickle cell disease predominates a different mechanism. There is a high prevalence of cardiovascular complications, cardiomyopathy, diastolic dysfunction, pulmonary hypertension, right heart failure due to pulmonary infarcts, and sudden cardiac death are most common causes of morbidity and mortality. Cardiac involvement in sickle cell disease arises from chronic anemia and HbS polymerization, leading to high cardiac output, chamber dilation, and eventual high output heart failure. Ongoing hemolysis and vasoocclusion cause nitric oxide depletion, inflammation, endothelial dysfunction, and diffuse myocardial fibrosis. Also, iron overload from transfusion and pulmonary hypertension due to hemolysis, hypoxia, and thrombosis further contribute to cardiac complications. Autoimmune complications reflect immune dysregulation from chronic hemolysis and transfusion, including alloimmunization. Neurologic burden reflects ischemic injury and chronic hypoxia, strokes, silent infarcts, cognitive impairment. Psychiatric manifestations come from psychosocial stress, recurrent pain, and hospitalizations. Interestingly, despite improved transfusion and chelation protocols, the overlap between systems suggests that organ crosstalk, for instance between the heart, liver, and endocrine glands, contributes to cumulative organ stress. The age gradient highlights how these chronic processes interact over time, a reflection of both survival success and emerging complexity of care in adults with hemoglobinopathies. So, to conclude, distinct comorbidity patterns. Thalassemia and sickle cell disease exhibit characteristic comorbidity profiles shaped by their underlying pathophysiology, endocrine metabolic in thalassemia versus cardiovascular neurologic in sickle cell disease. Comorbidity burden rises significantly with age, highlighting the cumulative impact of chronic treatment and organ stress, and emphasizing the need for lifelong age-tailored follow-up protocols. Systematic tracking of comorbidity patterns can enhance clinical planning, data comparability, and individualized patient follow-up. As survival improves, focus must shift from controlling anemia to preserving organ health and optimizing quality of life. And last but not least, worldwide collaboration amongst hemoglobinopathy centers will be essential to refine comprehensive care for an aging patient population. Thank you very much.
Thank you so much, Dr. Camposu. That was very enlightening. And I think you're very nicely placed in Greece, where you have a large population of both of these patient populations that are aging, and you're seeing those comorbidities develop. As a pediatric provider, we always counsel our patients about what could happen in the future, but as these patients are surviving longer, we're seeing what's happening to them towards later stages in life. So very enlightening. There is a poll that has opened up, so please, I would encourage all the attendees to be able to fill that poll, but I want to take a little bit of time for the Q&A. We have a comment actually from somebody who says that they could not participate in the monkey survey as Nigeria was not listed on the page. I will actually ask the organizers to answer that question. But before we go to that, there's a couple of questions for Darshi. So one of them is from someone who wants to know, what would you recommend as appropriate physical exercise for youth that are living with sickle cell disease?
Thank you for the question. For people who are following the general protocol of sickle cell treatment and intervention, I suggest, if they are living their life normally with all the medicines and all the appropriate intervention which is needed, they can perform, first of all, they can perform breathing exercises in the form of general deep breathing exercises that can be done regularly on a regular basis, or they can use spirometry on regular basis so that they can increase their oxygen capacity and their level of activities. Along with this, if they can do, they can start with aerobic exercises. General aerobics is start with walking, then mild running or cycling or swimming if they can do. It depends on their level of activity and the participation, how much they can participate in physical activity depend on individual, every individual. So breathing and aerobic, these are two things that can be done. If we talk about musculoskeletal performances, then you can do general stretching and general strengthening exercises for any type of pain if they find in their problem.
Thank you. The organizers are saying that we should try to wrap up the session. If the speakers could put their contact information in the chat. There were some follow-up questions about deep breathing exercises. And I totally agree with what Darshi just said. I think incentive spirometers are a very easy thing to get hold of. You could do that and a lot of other exercises that she recommended. But thank you all to all the speakers, and certainly I think if the audience has additional questions for the speakers and they're willing to share their contact information, that would be great. I will ask the organizers if they would like me to wrap up the session because I don't see any other questions in the chat. I think I have a question for Dr. Camposu. So amongst all the different comorbidities that you spoke about, is there any particular one that you think is really difficult for the patients as they're aging? You're muted.
Yes. Yes, I think numbers and tables don't always capture the human side. From what we see in the clinic, fatigue and bone or musculoskeletal problems probably have the biggest effect on daily life. They limit mobility, cause pain, and really impact independence. In thalassemia and on the other hand, endocrine issues like hypogonadism or diabetes also weigh heavily on quality of life, especially for younger adults. So yes, I think that musculoskeletal are those that affect them more.
Thank you. Dr. Kasner, one quick last question for you that I wanted to ask is, do you think that the approaches that you have shown in your MRI techniques could be adaptable to the routine 3 Tesla MRI machines if the neuroradiologists were trained to perform these once we have more data supporting early prediction of the different parameters that you showed on the MRI to be used on a more sort of clinical basis once the research emerges and matures?
Yeah, that is not an easy one to answer. For all these parameters I've shown, for the CVR, for example, we use some specialized equipment, a computerized capnograph to capture the end-tidal CO2 values. For the pulse wave velocity, we do something which is called radial imaging. That's something, which is not on everybody's scanner. So I recognize that. So we're also aiming for coming up with something which is more simple to do. For example, if you can just perform a resting state bolt scan, you need no equipment. And we also have computations for that to calculate vessel function from those parameters. So we're looking for an easier measure, which is more widely applicable. That is for sure.
That's fascinating. Thank you so much. Yeah. I think with this, we will probably end the session. Thank you to all our speakers for their expertise and for the answers that they provided. Yeah, I'll hand it back to the organizers.
Thank you, Dr. Kaker, for a wonderfully moderated session, and thank you to all the speakers for your insights from your various countries. Yeah, the next session has begun, which is the Industry Alliance Symposium. I put in the link for that session in the chat, or you can find the agenda as well. But we will see you in that session, and enjoy the rest of the Congress. All right.